Thank you. Are you able to see it?
Yes, yes.
Wonderful. Let me know when I'm good to commence, Wanapa.
It's good now. Thank you,
Wonderful.
Prof.
So, good morning, everybody. And I'm incredibly excited that today is Monday at 5 and I get to spend an hour with friends from across Thailand. So thank you for hosting me as always this time of the month. And as I was stating, two wonderful things to look forward to this fall. One is hosting colleagues from BDMS in Portland at OHSU. And the second is having the pleasure and privilege of joining you all in November. So thank you. Today, I'm going to present a case that was challenging, and I will present it to you as it presented to me. And this was on call night number 5 of the July 4th weekend. And started about Sunday at 8 p.m. in the evening. So this is a 64-year-old, reportedly previously healthy man with a history of hypertension and hyperlipidemia who presented to a community hospital in Oregon with acute respiratory distress and was diagnosed with cardiogenic shock. Due to the hemodynamic embarrassment and profound respiratory distress, he was intubated and sedated, and a shock call was initiated. And for us, that includes our critical care cardiologist, our ECMO team, our cardiothoracic surgeon on call, our advanced heart failure physician, and then the interventionalist. So on this evening, I was acting in the interventionalist, and our heart failure faculty serves as the point of contact during the discussions with the referring provider. The patient arrived and was profoundly unstable, had a PA catheter inserted, and was placed on 3 vasoactive agents, including norepinephrine, epinephrine, and vasopressin. The patient had a temperature of about 37 degrees Celsius, was initially tachycardic, had a pressure despite the 3 vasoactive agents of 90/62, and mean arterial pressure of 67. And on PA catheter, had a cardiac index that was reduced to 2 on vasoactive therapy, and a CVP of 12. Interestingly, had profound severe pulmonary hypertension with a pressure of 86/33, which in essence is similar, as you can see, to the arterial pressures. SVR index was markedly elevated, as was the PVR, with a reduced stroke volume. The patient was evaluated by our critical care team. A transthoracic echo was performed, and the patient was transferred emergently to the cardiac catheterization laboratory. At the time, the working diagnosis was a non-STEMI, complicated by cardiogenic shock, with an echo that showed reduced EF and aortic sclerosis, and was being transferred for placement of a circulatory device and consideration of culprit lesion and vessel PCI. When I was contacted, I stated that the picture didn't quite sit right with me, in that at 64, previously healthy, that the patient had systemic PA pressures without any history of pulmonary hypertension or any other chronic issues. So I was concerned that collectively we were missing something. This is the echocardiogram. And I would say the first thing is that there are poor acoustic windows. I see some aortic calcification, obviously the PA line, and I cannot see any of the endocardial surfaces. With contrast, as I take a look at all of the walls in this view, I see diffuse hypokinesis, especially in the setting of 3 vasoactive agents. But one can now see with myocardial contrast, good definition of the endocardial surface and the ability to see the contractile reserve of the myocardium. And I also see that there is uptake in this wall and in this wall of contrast into the myocardium. So we brought him to the lab with anesthesia support. And as always, we utilize a combination of X-ray imaging, upper limit being the upper third of the femoral head, coupled with ultrasound access to define when the common femoral artery bifurcates and to identify within the area of interest the least calcified segment in an effort to be able to utilize suture-mediated pre-close techniques for our large bore access. So one can see here no overt evidence of atherosclerosis, but a relatively small caliber vessel. This is a 4 French microcatheter dilator that we inject through. We can see the origin of the inferior epigastric vessel. And so we're in common femoral, hit at a good site, and went ahead and put a large bore impella sheath, and then did single access through that large impella sheath by inserting a catheter through it initially. And what we found was twofold: dense calcification of the aortic valve, which clearly is not aortic sclerosis, and no significant disease of the coronary vessels. This is streaming, and I'll tell you on other pictures, there was no evidence of any significant eccentric calcified stenosis beyond the origin of the first septal perforator. And so at the moment I looked at this, I said, what was perceived to be aortic sclerosis is likely severe aortic stenosis. You can see in the orthogonal view, selective angiography of the right coronary, which as well does not demonstrate any significant stenosis, and this dense calcification of the aortic annulus valve and some of the left ventricular outflow tract right here. And so now we're in a pickle because we have systemic pulmonary arterial pressures. We have arterial pressures that are just in the mid-80s systolic, despite 3 vasoactive agents. And, you know, the question is, given how young this person is, how do we manage him with systemic PA pressures? And what is driving the systemic PA pressures? So we did not think that ECMO was an option with the elevated PVR and systemic pressures. And after a lot of discussion, decided that we should measure left ventricular diastolic pressure and then make a decision about mechanical circulatory support with an Impella, given that RV function looked okay. So this is an AL1 with a straight wire. And I can tell you that over the straight wire, I could not advance the catheter. We attempted initially to cross with a pigtail, couldn't. AL1, we crossed, but we couldn't advance the catheter. And ultimately, we used a multi-purpose to get across and exchanged that for a pigtail catheter. And here are the remarkable hemodynamics. We have a systemic arterial pressure on 3 vasoactive agents of mid-90s systolic, and we have an LV pressure that was about 230 to 240. So over 100 millimeter peak-to-peak gradient. You can see here the beautiful pulsus parvus et tardus of the aortic tracing, how the peak is delayed relative to the peak LV, and how the upslope of the ascending portion is splayed and delayed and diminished. When one takes a look at the left ventricular in diastolic pressure, it was elevated to the tune of 25 to 30. So critical aortic stenosis with elevated left ventricular diastolic pressure and systemic PA pressures. So the team asked me, given how young the patient was and the timing, to put in an Impella, and I could not get it to cross the valve, which I was not surprised. We placed the exchange wire through the pigtail and then attempted, and this is one that comes with the Impella kit, but you can see I could never get the Impella portion beneath the aortic valve. And I'm going to pause at this moment and ask colleagues, what would you do in this scenario? 64 with systemic PA pressures.
Anyone want to start first? Can I start from group 6? Dr. Watanju, any comment from you?
Sorry, my signal is not so clear. I listen from my telephone. Sorry.
ครับผม
And for the record, I am not a TAVR operator. I replace pulmonic valves, but as a general rule, we do not do emergent TAVR on patients with systemic PA pressures.
Dr. Sigurua,
Yes, sir.
Before era of TAVR, we have case like this, and we have only intra-aortic balloon pump. So in my case, I'll use the Cribier balloon to do the balloon angioplasty for aortic valve, just to open the hemodynamic for temporarily. You know Cribier the balloon. It was
Yes.
it was designed by Alain Cribier, who passed away recently, to do balloon angioplasty. We have the chance to do some few cases. The result was quite good immediately, but it's not a prolonged. Just to pass in your Impella.
So thank you so much for that wonderful suggestion. So really the question, it's about midnight now, was whether I should do a emergent aortic valvuloplasty in a patient with PA pressures that at this moment were actually greater than the systemic arterial pressure. and without the capacity to emergently put a TAVR in. So it's about 1 o'clock. We talked about that, and the overall team agreement was to pause at this moment, given the super systemic PA pressures, and that a balloon pump at the moment would likely not be enough in this person, given the overall hemodynamics, and that we would bring together the team with the hope of doing an emergent aortic valvuloplasty, and if we cause severe AI, the immediate placement of a TAVR. In the overall reported balloon valvuloplasty, the series that was published, and I forget where it was, Circulation or New England Journal, took a valve area of about 0.5 or 0.6 to a valve area of about 0.9. And my interest for doing the valvuloplasty really was to be able to unload the heart and get the impella in and see if we could rest him and lower the PA pressures in order to eventually get a TAVR. So the patient was returned to the CVICU at about 1 that morning on epi, norepi, vasopressin, did a TEE, and now you can see extensive calcification of the leaflets and lack of any reasonable mobility of the leaflets, and in cross-section, the very highly calcified and rigid leaflets with a minimal orifice and antegrade flow. So I had pre-closed him on the right femoral. So we approached him via the left, and with the planned antegrade access via the SFA. So again, we used ultrasound guidance, X-ray guidance, angiographic confirmation, and then went ahead with our large bore sheath. Antegrade access because we knew the sheath was and the impella would be in for some time. Once again, we utilized an AL1 and a straight wire, used a 22 millimeter Z-Med balloon, which with rapid pacing. When we first did aortic valvuloplasty, we would not do rapid pacing, but it's now part of our standard protocol. Fortunately, the balloon did not rupture, and you can see that the peak systolic pressure of both the LV and the peak aortic both reduced, and that the gradient was reduced from about 50, from about 65 to about 45. So there was a reduction in overall gradient. Hard to know whether the actual valve was markedly impacted, but it did give us a room to then advance the impella catheter from the left femoral artery retrograde across the aortic valve and begin to unload the LV and improve the output. And it was clear that there was very little outrun immediately on the 3 vasoactive agents, despite doing fem-fem bypass with the right femoral sheath antegrade and a left superficial femoral retrograde. There was no palpable pulse or dopplerable pulse. And you can see how with injection, there is just stasis of dye. and very little flow down, towards the ankle and foot. And I think this is a combination of profound vasoconstriction on 3 vasoactive agents. There was no evidence of clot. We left both the antegrade and retrograde sheaths and heparinization to attempt to perfuse that left leg and sent them back to the CVICU. I'll remind everybody that vascular complications are the bane of large bore access, despite the techniques that we employ, and that anywhere from 1 in 3 to 1 in 5 will have bleeding and or major vascular complications. So, we were concerned about the leg. We were happy that we were able to markedly reduce vasoactive agents. Bleeding is a major issue on both ECMO and other MCS. We had done the 2 PERC closes, tightened them, gave a little FFP and little blood. Unfortunately, that caused complications in our reperfusion catheters, and the left leg became markedly ischemic. One can see in the right that PA pressures remain elevated at 86, but that the norepinephrine was weaned off. Epi remained at 0.06. Vaso was still high dose at 4 units, and we were flowing at a reasonable rate. The patient ischemia caused compartment syndrome, and we had to proceed with 4 compartment fasciotomies of that left leg, expose the femoral artery, retrieve the device, did thrombectomy of the left leg, and went ahead and did a saphenous venous bypass, exposed the tibial artery, and close that with a vein patch procedure and pericardial patch angioplasty of the popliteal artery. So following treatment of the very challenging complications of the left leg, we proceeded back to the cath lab and placed a 26 millimeter Edwards, and you see that being positioned here. You see the annulus, and you see kind of this 90-10 deployment. That went really well. Minimal paravalvular leak, and you can see a little bit of contrast there. And his hemodynamics markedly improved. The systemic mean arterial pressure was 76. PA pressures remained elevated. We treated him with diuretics, ongoing heparin for anticoagulation, and a bit of milrinone to support his forward flow. We can see that tranthoracically, especially here on the right, you can see that his LV function is now hyperdynamic when using contrast, and he continued to improve and was transferred out of the cardiovascular ICU to the step-down unit. And then it was a matter of patience, coupled with careful washout of his fasciotomies and debridement to minimize the increased risk of bacteremia and endocarditis. And he was fortunately recovered to the degree that at 5 weeks, we were able to discharge him from the acute hospital to an ongoing care at a rehab hospital, primarily for the the wound issue. So this is a presentation that I thought, as we are contemplating how we expand transcatheter techniques and circulatory support, an important case to demonstrate a multidisciplinary approach to saving a life, and unfortunately, some of the challenges that go with saving a life, incorporating MCS therapy, how we choose the MCS therapy. In this case, we didn't think we'd be able to flow with ECMO given the profound pulmonary hypertension. So it was humbling. Ultimately, he did survive. And, it took a team of very talented people from different disciplines to, and lots of resources, to get him through this acute event. I'll pause there.
Ajahn Namrat, you want to say something?
Yeah, that is a very, very excellent result of the multidisciplinary team and of the skill technique and how to care and manage patient with severe AS and cardiologic shock. We learned a lot from just beginning before you start the procedure by putting PA catheter, doing the contrast echo, and then follow all the step techniques, measure the LVDP, measure the PA aortic valve gradient, and follow on from that. One thing that I missed is is there any critical narrowing in the mid-LAD from your angiogram? I saw only one scene on the IO caudal. RC is normal, circumference normal, but just only the LAD. Is that cope with the non-STEMI with AS?
Yeah, no. So one, thank you for that feedback. Better injections, I'm sorry I didn't capture different views. It really was streaming. We repeated multiple views, including that, and there was no significant disease in the mid-LAD after the first septal perforator. I think to me, the challenge from the beginning, and I walked into this case as a proceduralist, and I challenged our team to challenge themselves when I was told that the PA pressure equaled the aortic pressure, and this was acute cardiogenic shock secondary to non-STEMI. I said, that may turn out to be the case, but I doubt it. I said, there is something that has not yet been appreciated, because acute cardiogenic shock does not cause PA systolic pressures of 90 to 100. That RV will fail at much lower pressures. And as it turns out, the severe chronic AS that turned to critical AS and pushed him over was the primary reason for a chronically elevated left ventricular diastolic pressure and associated acute on chronic elevated PA pressures. And to me, that's where I hung my hat on from the moment that I heard the case. That didn't sit well with me relative to the operating premise that the team had.
When you do the angiogram on the common femoral artery, you saw that the artery is relatively small. Are you prepared that the patient may have the ischemia compromise after passing the big sheet for impella? I saw that the diameter is quite small for 64 years old man.
Yeah, so the good news is on ultrasound, there was no calcification. It looked like a beautiful vessel. And our thoughts were that it was primarily vasoconstricted due to a combination of hypoperfusion and vasoactive agents that we not uncommonly see in this scenario. Despite that, because we could not flip a switch and acutely cure his cardiogenic shock, we were absolutely prepared. And despite that preparation with antegrade perfusion catheters and cross fem-fem perfusion from the other, we still were unable to avoid the ischemia. I'm happy to say that we saved the leg and that the leg did not have to get amputated, but you saw the remarkable and disturbing images of the acute ischemia and how we had to treat it.
Yeah, this is one of the bravest procedure that I've seen. I have to name it. It is a Justice League of an Extraordinary Man.
I knew I forgot something. I needed to bring in some title from some movie, and so far I've been unable to do so, Dr. Damras. I have failed yet again on that.
All you guys are extraordinary men.
Prof, I have a non-cardiologist question. If it's not at midnight, immediately after the major public holiday, if it's happened during daytime, weekday, will you do anything differently for this case?
I think that the maybe the only difference, but it really was more about daytime, was getting a broader perspective as to whether we were going to do the extraordinary given the horrific pulmonary pressures. And to me, that really needed a greater buy-in from across the group for us to take that risk, and a greater discussion with the patient's family to have them understand really what we were up against. And so I think that we still would have paused and had those discussions. They probably would have occurred over a series of hours. And in the middle of the case, and technically this was an incredibly challenging case, I still reached out and called a friend, another senior experienced individual, to run through all of the options, like you say, Wanapa, and determine what we as a team were willing to do with the limited knowledge of somebody we had just met with these systemic to suprasystemic PA pressures. That to me was the challenge here. If it wasn't for that, I would have immediately valvuloplastied him and put in the Impella myself. I just didn't know in itself, would that be enough and what would we do? And hadn't had the conversations yet with the family and the larger team to say, is he willing to, are they willing to, are we willing to?
Thank you. I'm curious, I have seen some cardiac surgeon in this video call as well. So I'm wondering, is there any extra viewpoint from the surgeon for this case? I have seen Ajahn Chusak and Ajahn Phumyot in the video call. Anything to share your thought?
From surgical, I have two questions. One is about this is a bicuspid aortic valve or tricuspid aortic valve stenosis. The first question, and the second one is a combination between stress-induced cardiomyopathy and CVS in this case.
Yeah, those are tough cases, right? And I think that's really interesting that you bring in the stress or so-called Takotsubo cardiomyopathy, which at the outset we thought was relatively benign, but as we've learned more, and the morbidity and the mortality is not low in Takotsubo.
Because my point is that there is a full recovery of every function post TAVI or post angioplasty. Something and in the first attack, they need the IV notrol high dose, so we can use like the cardiopathy from the IV notrol at the first time. That's my point. Thank you.
Thank you. Well, I really appreciate the opportunity of sharing with you as a group this humbling case that gave me, from a approach perspective, a lot of challenge, and simply the technical components of the procedure were quite challenging. The aortic valve, it has never taken me as long as it did to cross that aortic valve in my 30-something years of doing procedural cardiology. It was brutal.
Any comment or any question from other side, please?
Yes. If the patient, I am Dr. Chusak from Phuket. I think that if for the first time that I saw the patient, if the patient in cardiogenic shock and we cannot raise the blood pressure or anything by the medication. So in my hospital, we only have the ECMO. So sometimes we push the ECMO in first and then make the investigation what for we can do for the next and make a judgment from the investigation. If about the severe AS, we have the choice. Here we cannot do the TAVI. So if we cannot do TAVI, we will have to refer or to talk to the patient about the risk of the open surgery for the aortic valve replacement. I am the surgeon, so I think that it may be if after the ECMO, the patient look good enough to do the surgery, we do the surgery. That is my idea for the limited resource.
Yeah, I think that certainly is not an unreasonable approach, but with the PVR that this patient had, I'm not sure that they ever would have come off of cardiopulmonary bypass, but you know, he was 62 or 63 years old, and it's hard not to do something, right?
And any other comment? Ajahn Phomyot, you want to say anything?
It's a high risk case, so I will talk to the patient and I will give them a choice to do the valvuloplasty with the catheter and do the same and do the open surgery. But I think maybe the valvuloplasty and maybe it's better option.
Yeah, I certainly would agree with both statements that to put somebody on circulatory support, one would have to see an improvement in the hemodynamics. And even taking a valve from 0.5 to 0.7 or 0.8 or 0.9, coupled with the mechanical circulatory support, would give one a reasonable chance of seeing whether that improved the patient enough to survive another procedure such as a SAVR, you know, or a TAVR. And I think that's the reasonable approach. I think the wrong approach is to put them on mechanical circulatory support and go straight to either TAVR or SAVR.
Dr. Siguro, because this is an emergency TAVR, how do you measure and sizing of the valve? Because like routine, you have to do a lot of processing. But in this case, I think that you have no time. So you have to judge and use your gut feeling to select the 26 millimeter the stand, the graft.
Yeah, we go back to the humbling times of doing our TEE measurements, which are less good than the aortic annulus measurements, especially with the bulky calcification. Clearly, transthoracic, no way, no how. TEE to try and measure and get an okay result, right? I mean, you're not trying to go for perfection here. You're trying to take somebody who is dead on your table, in essence, and give them the opportunity to live and fight another day. And that's what we did.
And at the end of the procedure, is there any paravalvular leak?
Trace, by both echo and aortography.
Yeah, that's excellent. Extraordinary man result.
So the TAVR was done by my colleague Harsh Galwala, who members of your team will meet when they visit in October.
Ajahn Amon, I've seen your name joining as well. Any question or comment from you, ka?
So would like to ask you about the role of the new medicine like levosimendan in patient like this, because I see some articles about using levosimendan to support the patient with from variety caused from Takotsubo to septic cardiomyopathies, whether it could help in this situation.
Yeah, there really is no data for it, so it would be hard for me to provide guidance on that. And what I would say is that in the walking cardiogenic shock patients, so hemodynamics embarrassed, but they've been chronically embarrassed, the careful role utilizing arterial line and a PA line for judicious use of afterload reduction, with nitride to improve the hemodynamics. The case I showed today is not the case to do that. But there are individuals who have mean arterial pressures of 62, 65, cardiac indices of 1, 2, 1, 3, and SVRs in the 2,500 to 2,800, in which you can very carefully afterload reduce them to improve the cardiac index, mobilize volume, improve renal perfusion, and get them to a point where you can do that valvuloplasty and TAVR at the same setting.
Dr. Siguro, may I ask you from the beginning, back to the beginning, you mentioned that this gentleman was transferred from a community hospital. Is that hospital is under your referral network, under OSU, or it is your enemy hospital?
No, there are many strong competitors who choose to call us on the weekends with cases like this. But no, this is one of our aligned allies.
I agree that in your referral network, you have to accept all these difficult cases. But in
Yes.
Thailand, we saw that we received the difficult case from the competitors.
Yeah, especially on New Year's Eve and other beginnings of long holidays. We appear to have more people who are interested in using us for cases like this. But no, this was one of our collaborating wonderful partners.
Thank you.
That is excellent, very excellent teaching case for how to manage we call chip case, and with all the modality that you have mentioned. We hope that our team will learn from you with this the ongoing visit to OSU.
I have seen
Wonderful.
Dr. Ongkan join in as well. Dr. Ongkan, you have any question or comment for him?
I think that was a fantastic case in the fantastic team. But for me, I think I will put the patient on the ECMO first, and maybe I will call my surgeon to talk about the risk of the the surgical aortic valve replacement, because at our hospital we don't have the guy that can do the emergency TAVR at nighttime in the a long holiday like that. So I think that was the fantastic thing.
Thank you for those comments. I think those are all valid points. And most people, when the PA pressure is 100, 110, and the systemic pressure is 90, not many people will place those people, on ECMO, at least at our facility or the US. And the challenge is when you don't have alternatives, what do you do? And, it's not easy. And then you have to be prepared for the river you've chosen to sail on and all of the challenges of that river, which, we showed you tonight or this morning.
Ajahn Namarat, I just want to ask one last question. Anyone else have any final words to ask before we can potentially move to the extended discussion Dr. Damrat proposed earlier? มีใครจะถามเพิ่มไหมคะคำถามสุดท้าย Dr. Samran,
Just a comment, and I failed to say it at the beginning, although it was on my slide. Much thanks to my audiovisual colleague and my fellow who was involved in all facets of this case that weekend, Coulter, who helped me with the audiovisual and the playing videos and all that so it would work, as opposed to what might have been presented if I had done it by myself.
that is understood, Prof. We feel the same way. Dr. Samran from RPH, anything from you? Any question?
Justin, did you like that case?
It sounded a little bit frightful. How did you feel going through? Were you a little bit nervous?
Not nervous, but I was a little bit sore the next day and tired. There are no nerves. You can only do what you can do.
Yeah, pretty amazing save there.
And only 5 weeks in the hospital, that's amazing, considering many eventful series of things. อาจารย์นำรัตน์คะ actually no more question อาจารย์จะพูดเลยก็ได้นะ
Yeah, Dr. Sikalua, for the also visit to Bangkok, you have a keynote lecture for our annual meeting on Friday. So I'm going to propose you a we call site visit to RPH. That is our one of the youngest Center of Excellence, RPH in Cambodia. But because we promised to each other last year that you should come a little bit earlier, then we can take you to a tour to Angkor Wat, Angkor Thom. That is one of the 100 places that you have to see before you die. If you agree with that, we do site visit on first day on Monday, the first day of the week at RPH. And then we'll have a symposium for all of the Center of Excellence to attend by online. But on face-to-face, we'll have a invitation to our colleagues from Cambodia. We call Calmet Hospital. That is a public hospital that is close by. And then we can introduce you Oregon Health Science for your fantastic work. You may select your preference lecture to give the knowledge to Cambodia doctors. And also that is a 10-year anniversary of the RPH established in Phnom Penh.